Good evening. Welcome to the Vaccine Facts Town Hall. First, let me introduce myself. My name is Jennifer Mata Gomboa, registered nurse and secretary of the Black Nurses Association of Central Illinois. I will be the moderator for tonight's educational town hall. This evening, we want very much to provide you with accurate information and to respond to concerns you may have. There has been some incorrect information circulating, myths that can be alarming. We want you to have the most accurate and most up-to-date information to use in making your decision about vaccinations. In addition to a brief educational presentation, the doctors will be answering some of the most frequently asked questions. We know you may have additional ones. We encourage you to ask them. You will also hear from the president of the Bloomington-Normal branch of the NAACP. And at the end of our closing remarks, we will list the sponsors of tonight's town hall and have information where you can go for additional information and if you need assistance. You can type your questions into the question and answer area at any time during the town hall. Just click on the Q&A icon and type in your questions. We want to have all your questions answered, so please add them at any time. Immediately following the slide of the town hall sponsors, we will have a slide with important COVID-19 information and how to get assistance if needed. You can write the information down or take a screenshot of the slide. We will keep the slide up for several minutes. Now, we will have brief remarks from Dr. Ansel Johnson, President of Healthy Living with a Vision Foundation. Thank you, Dr. Johnson.
Thank you all very much. I am blessed and so excited to be part of this collaboration. I'm the President and CEO of Healthy Living with a Vision Foundation. And when the McLean County Health Department came up to ask us in collaboration, we were really excited because we're really about dispensing information and about lowering the barriers and equalizing the healthcare disparities in communities of color. I'm especially excited because I went to undergrad school at Illinois Wesleyan in the area, so I'm very familiar with the area, excited about collaboration. And at the end of this broadcast, we are a not-for-profit foundation, and I would just ask if you all click on our website at healthylivingwithavision.org, and whatever donation you can see that you feel you're able to do, we really will welcome it so we can continue this great work. Secondly, on our website and our Facebook page, we have continuing information not only on COVID vaccine, because this is an ongoing issue that's going to be with us for a while. Information is always changing, it's dynamic, and we did our first town hall meeting in January 3rd. And we have so much more information now than we did before. So again, it's a blessing and a pleasure to be a part of this, a great collaboration. And thank you all very much.
At this time, Dr. James Thompson, also with the Healthy Living with a Vision Foundation, will share facts about the vaccine. Thank you, Dr. Thompson.
All right, thank you. Thank you for the invitation. I'm very glad to be here tonight. Unfortunately, this is a landmark day because I think we hit 500,000 people that have died in just this country from COVID-19. So I think it's very appropriate that we have this discussion. So perhaps that number can go down as we make informed decisions. Just a little bit about my background. I've been in practice for 31 years, and I'm an allergist and immunologist. And I practice in the Chicago and greater Chicago area, and I see all ages. I'm going to now share my slides, so let me see if I can do this expediently here. Let's see. All right. There we go. Can everyone see it? I hope everybody can. The first slide is an electron micrographic colorful slide of SARS-CoV-2. This is the virus that's causing problems around the world. This is how it looks up close and personal. Even a high school or college desktop microscope couldn't give you a picture like this. It takes an extremely powerful microscope because they're so small. But the SARS-CoV-2 is the name of the virus. COVID-19 is the name of the disease that the virus causes. So actually, you don't catch COVID-19, you catch SARS-CoV-2. The name of the virus, SARS, standing for severe acute respiratory syndrome and the COVID for coronavirus, and the two because it's the second generation. It's actually a cousin of the first SARS that came out in 2002. Notice the red structures there. Those are the spike proteins. Those are not only the targets for all the vaccine platforms that are out now, and the two vaccines that are out, and the ones on the horizon, but these also represent the structures that allow this virus to attach to our cells and infect us. And so this is a cartoon of it that also shows the strip of genetic code that is enclosed by the outside surface of the virus. That genetic code allows it to make more viruses. So what happens is this virus attaches to receptors on cells that are in various tissues of our body, starting with the upper respiratory, and getting down into lung and many other tissues. And they're called ACE2 receptors for angiotensin converting enzyme. And inside as you can see up top to the left, is RNA, which stands for ribonucleic acid. That's the genetic code of the virus. Some viruses have RNA, some viruses have DNA. This particular coronavirus has RNA, and that's what allows it to replicate. So once it's able to get into our cells, it does what most viruses want to do: infect cells, exponentially replicate, and then leave so they can affect other cells and then other people. And the way it does it is by hijacking the cell's machinery. They're called ribosomes. They're like chefs, 5 million of them or so in a cell, that are able to read the recipe of that RNA and make more viruses. And so once that happens and it spreads to other parts of the body, one can see that other tissues can be involved. So these are the heart, where you can have heart failure, you can have irritation of the heart and heart rhythm disturbances. The kidney has ACE2 receptors too. Kidney failure can occur because of this virus. Acute liver disease can occur, increasing your likelihood of having diabetes, making it hard for you to detoxify drugs and other things you might consume. The pancreas, where there are beta islet cells that can get attacked, and therefore you have diabetes. You may start off without diabetes, but then have COVID-19 and get diabetes. And then other organs, the brain, which means that can cause dementia and confusion and seizures, and the bowel, which can cause diarrhea. And we most hear about the lung, where it goes to the lung and causes fluid and pneumonia and something that has a high mortality rate. ARDS, acute respiratory distress syndrome. Most people that experience that have to go on a ventilator. And so when we look at how we've dealt with viruses in the past that can cause pandemics, vaccines have been a way to save millions of lives. And the way they used vaccines, or the way they designed them before, was to either use a weakened vaccine particle or one that was killed. That also means inactivated. Or they took a piece of the virus or protein and used it to inject and form and establish an immunity. To the right, you see here, though, a brand new platform, new in terms of it being used as a vaccine for this disease. And it contains just a strip of genetic code. It does not contain the whole virus, just the small strip of genetic code that makes spike protein, those red structures I showed you. And so the take-home message here is that the vaccines cannot cause you to have COVID-19. They do not have the genetic code for the entire virus. So there's no way you can get the COVID-19 disease from the two vaccines that are available now. Now, in the olden days, actually not so old, still a lot of flu vaccines and various other vaccines are made by using fertilized hen eggs. So tens of thousands of hens and hundreds of thousands of eggs are used and then reused once the virus is grown. And this takes weeks to months. But that's not something that's needed now with these new platforms that just use genetic code. If you went into a laboratory several years ago, back in the 1950s, it would look much like this. And notice that there's a lack of diversity in this lab. Whereas if you go in many of the labs today, you see a more diverse mix of people that are working and doing research. And if you go into the NIH lab, the main virology lab, you would see that there's a director here by the name of Dr. Kismethia Corbett, To the right, you see Dr. Anthony Fauci. She's actually giving them some information. She has been involved with the development of the Moderna vaccine from the very beginning, but she's been studying SARS since the first generation SARS, and as she worked on her PhD at Duke. So she's been at this for several years. She realized that when the first SARS came out in 2002, that if this disease that didn't kill as many people but was very contagious, kind of hooked up with the characteristics of the MERS, the Middle Eastern respiratory virus, which was not contagious but killed a lot of people, that we could really have a pandemic on our hands. She thought about this 6 to 8 years ago, and then came SARS-CoV-2. And so the messenger RNA platforms, I want you to know, have been studied for about 20 years now. This is Katalin Kariko, a scientist from Hungary, who studied this and came up with it came up with a brainstorm long before anybody thought of it. But her work kind of went unnoticed until about 7, 8 years ago, when some professors at Harvard just took it to another level and decided to form the company Moderna, which stands for modified RNA. So my point is that this research, both the platforms of messenger RNA and the SARS generation of coronavirus, have been understudied for 2 decades. And so now we have the 2 vaccine platforms that are out, the messenger RNA platforms. To the left, we have the Moderna, and to the right, the Pfizer-BioNTech. These are the names that were used before they were given the fashionable names that we know of now. And so both platforms use a bubble of fat they have a nanoparticle, meaning very small particle of fat, with the messenger RNA strip in there. This messenger RNA, you must know, does not contain the whole viral genetic code, so it cannot make virus, only the spike protein. And so once it gets injected, it goes into the muscle cells, and just like the virus, it instructs these ribosomes, which are like chefs, that make this recipe off the messenger RNA of just the spike protein, which is then presented to our immune system so that we can develop an immunity, so that the next time that if we happen to be exposed to the virus, there's a swarming of antibodies that come and take out the virus before it can attach to our cells. And I just included here the other constructs that are coming along the way. You may have heard of the Johnson & Johnson vaccine and the AstraZeneca vaccine. They have they use virus vectors called the adenovirus. So they do use a virus vector, and they do contain DNA. So DNA stands for deoxyribonucleic acid. And so they've removed the parts of the genome, the genetic material of the vaccine, of the virus vector, so that it can't replicate. So it can't make more virus particles. It can only make spike protein. But unlike the messenger RNA, it does go into the nucleus. Like the 2 vaccines that I mentioned before just stayed out in the cytoplasm, the surrounding area of the nucleus. They were RNA. RNA doesn't need to go into the nucleus. But the DNA viruses do, but they don't, according to bioengineers, go anywhere near our chromosomes. They don't mingle or all have anything to do with our genetic code. They just get transcribed and then go out into the cytoplasm and make spike protein like the other vaccines. And so moving along, we have the 2 platforms here, one that does involve DNA and goes into the nucleus but comes out and makes a spike protein. The other one that just has messenger RNA to the right and makes spike protein. They both end up in there being an immune response that allows us to be protected. And if we look at the studies, the 2 studies, the Pfizer study had 40,000 people, 44,000 or so. The Moderna study had 30,000. And the nice thing about it is they included a diverse group of people, almost 10% African Americans in the Pfizer and Moderna studies, and overall about 26% of Hispanics. And so a very diverse group, very diverse socioeconomic characteristics. So a very well planned study with lots of people. If we look at people that are involved in the administrating part, with respect to the FDA, we have Dr. James Hildreth, who's the CEO, the chair, president of Meharry Medical College. He's on the board that approved the vaccine, the advisory panel that approved the vaccine for the FDA, as well as Ovito Fuller, Dr. Ovito Fuller, who's a virologist on staff at University of Michigan. And this is Dr. Chris Purnell, whose father passed in April from this disease, and she decided to volunteer for the Moderna study and has been vaccinated and is working in public health herself. And so I'm gonna finish with this slide. This shows herd immunity. This is what we're trying to achieve with vaccines. Vaccines save lives. And when you decide to get a vaccine, you're making not just a personal decision, you're making a societal decision. Because once you're protected, if you look on the left, the herd immunity, the red is an infected person, the blue are people that have been vaccinated, and the clear structures, the clear individuals are ones that are at risk. They don't have antibodies. They haven't been infected by the virus and they haven't been vaccinated. If you look on the right though, that's a community that's going to have a lot of problems because a lot of people are not vaccinated. A lot of people have not yet had the disease, as is the case in this country. The majority of people have not yet had the disease or been vaccinated. So people are not as protected. So the bottom line is currently available vaccines will not and cannot cause COVID-19. The messenger RNA research goes back 20 years. So does the SARS research. Advances in technology are what led them to go from 0 to 60 here, from January to having a vaccine available before the end of the year. And people of color are well represented throughout areas of the research for this and administration. And I believe I have gone through my time. So I'm going to pass the baton here back to the moderator, Jennifer.
Thank you, Dr. Thompson. That was amazing. Next, our panel of local doctors will introduce themselves. After introductions, we will begin the question and answer portion of the town hall. To ask a question, click on the question and answer icon on your screen. You can add questions at any time during the town hall. Without further ado, our panel of doctors will introduce themselves and then we'll start the question and answer portion. Again, you can type in your questions at any time during this segment. Dr. Galloway, if you could please start us off.
Good evening, everybody. My name is Dr. Galloway. I'm a primary care physician. I'm trained in internal medicine and family medicine. I've been practicing for more than 35 years. I work at OSF College Avenue. I've been there since 2009. I just wanted to say something important that I did get the vaccine. I was happy to be one of the first ones, first group on December 23rd. And I've had my second vaccine and I can say there was no major side effects. So just to all those people who are worried about the side effects, just want to reassure that as a physician, I believe that it is the only step we can take to control this terrible disease.
Thank you, Dr. Galloway. Dr. Ogunle, if you could please go ahead.
Hello, my name is Dr. Dele Ogunle. I'm an obstetrician in Bloomington-Normal. I have been in practice now for almost 20 years. I'm in private practice, advanced women's healthcare. And I have also, like Dr. Galloway, obtained the vaccine. I had my first injection just after, I think it was on 26th, close to Christmas Day last year. And I had the second vaccine, or second dose, maybe just about 3 weeks ago. And I did get the Moderna vaccine, just like what Dr. Thompson was saying. On a personal note, I lost my father to COVID about maybe April last year, almost 10 months ago. So I'm excited to be part of this forum to talk about vaccinations and how we can reduce the risk to everyone. I'm sure my dad would really want us to get this word out. Thank you.
Thank you, Dr. Ogunle. Up next, we have Dr. Pendleton.
Hi, thank you. Hi, I'm Dr. Deanna Pendleton. I'm a board certified family physician, but I currently work as a hospitalist. I'm the medical director of the hospitalist program here at Carle Medical Center. Basically, I see all hospitalized patients in the hospital, my team and I. I've been here for 7 years. I've been a physician for 14 years. So I also got my vaccination. I got the Pfizer vaccination My main side effect was very sore arm the first time. My second vaccination, I maybe had a little chills, which can be a side effect, but I did fine, and it's not uncommon. I really do encourage everyone to get the vaccination. I know my personal family members, when I first told them, when it first came out, and I said, I was the first wave here at Broman, and I text my family and I told them, oh, we're going to get the vaccination, and you should have saw the emojis that I got. So, but now my family's on board. So I just want to encourage everyone to get the vaccine also.
Thank you, Dr. Pendleton. Dr. Tillman?
Yes, I'm Dr. Anita Tillman, and I'm a pediatrician. I work at the Advocate Broman Outpatient Center, and I've been here been a pediatrician for over 20 years. That's painful to say, it's been that long, but it's true. I highly endorse vaccines. I mean, as a pediatrician, that is what we do every day, all day long. And I did get the vaccine. I got the Moderna, and I have received both. And again, the first dose I got, my arm was sore, and the second time as well, my arm was pretty sore, but no big side effect. And those are things that we warn our patients every day to expect to have that type of side effect. So, that's just a sign that your immune system is working. So I'm very happy to be here to participate in this. And I greatly thank Dr. Thompson for mentioning how long they have been working on this vaccine, and that this technology is not just created since last March. I think some people have gotten the impression that they've gone from 0 to 1,000 in that short period of time. And, in pediatrics, we've seen many vaccines developed and, have seen the time that it can take. And so, even I was skeptical before I looked into it and realized that it had been researched on boards before we started, saying that it got created from March until January or December when we started giving it. So yeah, I'm very happy to have received it, and it makes me feel much safer and more confident in taking care of patients and being able to do it safely. Thank you.
Thank you, Dr. Tillman. We're going to go ahead and start the question and answer section of this town hall. And our first question is actually for Dr. Tillman. And it is, we have heard a lot recently about getting schools reopened, especially K through 8th grade. Is returning to school safe?
Yeah, I mean, that's a question that I talk to my patients about every day when they come in and they consider whether they should continue with remote and whether they should continue to advance to doing the hybrid model. Now, in our community, in Unit 5, which is the normal schools, actually K through 5 is going back to school every day. And so far, it's been good. They've been very safe. We do get a lot of patients sent to our office because they go to the nurse and say they have a stomach ache, they have a headache, and so they're sent to us for us to make an assessment and decide if they need to have a COVID test, if they have an alternative diagnosis, or if they need to stay home for 10 days. Now, when the kids go to the teacher, they actually will send that child home as well as their siblings. So parents are not happy with this, but I think that that is one of the strategies that they have to use in order to maintain safety, as well as the every other day schooling, so that there's less kids in the classrooms and that there is, more opportunity to have them washing their hands and to clean the areas that they are, participating in. As a community and as the school districts, they have to consider what is the burden of the disease in the community, where they can use either the percentage of positive tests or they can use the number of illness per 100,000 people to decide if they think it's safe to go on. I think some school districts even consider what has their experience been in the school. So if they have low cases in the school, sometimes they are going to open and they're going to continue. We do have some schools, some of the smaller communities that have been opened, and we also have some of the private schools that have opened and have been pretty successful. The parents are aware that if their child is sick, to keep them home, and they're aware that if their child goes to school and has any complaint, that they're probably going to be sent home. So they've done a good job with that. sometimes they are a little bit very conservative, and it could be a child is not really that sick, but they show one of the signs. And there's many signs, so sometimes it could be an alternative diagnosis. It could be just a brief symptom of a stomach ache that kids have all the time at school. So that has been a difficult thing, but I think that that's normal and they've handled it well. So, I do think that it is safe. I think that they're using good strategies in order to keep the kids in school. I think that it's important for them to return to school. We are seeing a lot of kids who are struggling with their mood and with their depression, with anxiety about being out of school, as well as missing their socializing and their friends and their sports. So as far as what I have seen, I feel confident. And my feelings have changed. At first, I was very concerned about them returning. I do think one important thing for a family when they are deciding if their child should return is, are there risk factors in their child? Asthma, diabetes, anything like that, as well as are there family members who have high risk factors that would make it dangerous if that child did get COVID, for them to share it with that family member who could be at high risk. So sometimes the decision the family has to make is more based on the family members in the household and not necessarily for the child. For each family, I feel it's very individual as far as if they have any diseases like diabetes, asthma, whether they should return, and again, whether there's any family members who would be at high risk if they were to get COVID. So in general, the infection is a mild disease in children. The kids that I have seen in my office who have tested positive actually look like they have a cold. We've had very few very ill children from COVID. And so most of them have had brief illnesses that perhaps the parent wouldn't even have brought them in, except they're directed by the school that they need a note and the child needs a physical evaluation in order to return to school. So I do feel that most kids are very safe and will have a mild disease if they do catch COVID. But again, I think the schools are using good strategies with reducing their exposure to the illness.
Thank you, Dr. Tillman. That was a very thorough answer, and we appreciate it. The next question I have will be for Dr. Thompson, and it's sort of a two-part question here. So it is, give me a second here. What is the worst case scenario of someone experiencing an allergic reaction to the vaccination? And if someone has allergies specifically to penicillin, are there any concerns with getting the vaccine?
Okay. Okay, I'll take the first. Of course, the worst case scenario of any reaction, whether it be allergic or otherwise, is dying from it. Now, next to that, of course, is near death. And fortunately, now after 40 plus million vaccinations in this country, we're just not seeing fatalities from allergic reactions. There have been some very severe allergic reactions where people may have had to stay monitored for a few hours in the emergency room, but no one's had a fatal, or to my knowledge, a near fatal attack. There's just been some severe allergic reactions. And there appear to be a subset of people that may be more at risk for that, like people that have a history of multi-drug allergies already. Now, I'm not saying someone that just has one allergy, who are allergic to even penicillin, or had one food allergy. I'm talking about a subset of people that have multiple foods, multiple history of medication allergies, or even an allergic reaction to a vaccine previously. Those people, we'd want to take special precautions. They can still often get it, and I have some patients that are like that, and we take special precautions where we want them to get it in a hospital or clinic. We want to make sure they have the epinephrine with them. We want to make sure they are getting it where there are doctors around, where they are skilled at treating severe allergic reactions. The person that absolutely should not get it, they call that a direct contraindication, is a person that had an allergic reaction to the first one, even if it was a mild allergic reaction. Say you had hives after the first Moderna or Pfizer BioNTech vaccine, then you shouldn't get the second one. Or if you had wheezing or any allergic type characteristics. Now that doesn't jive with the reactogenic type of effects that many people get, or to some degree, like some fatigue or headache, or even just local soreness, even though it may be very sore. Those aren't considered allergic reactions, and so those people that experience that, as already been mentioned, that usually means that it's working, and so you should definitely get your second injection. Now, as far as penicillin, history of penicillin reaction, I follow a lot of patients that have a history of penicillin reaction, and we don't hesitate to let them go forward and get their shots without special precautions if that's the only reaction. Penicillin, there is no antibiotic in these vaccines. There's no residue of antibiotic, as opposed to, say, the flu vaccine, which if you're allergic to neomycin, there may be some increased risk, but there's no antibiotic residue in these. And so if you're allergic to penicillin, it does not create any increased risk for you.
Thank you, Dr. Thompson. The next question is for Dr. Ogunle. Is the vaccine safe for pregnant women, and can the vaccine affect fertility?
Thank you, Jennifer. That's a good question, and that's probably a question I get on a regular basis from my patients. Through this time since we've had COVID with us or around us, a lot of pregnant patients or soon to be pregnant patients have gone through different levels of anxiety. It's either been, am I going to get COVID, or am I going to pass COVID on to my baby, or can I actually get pregnant in this time? So one of the things that I've actually tried to do is to kind of break it down to them to say, yes, you should get the vaccine. Majority of patients at this point in time are getting to the point where they have access to the vaccine. It used to be that there was an age group that they were offered the vaccine first, and many of those people over 80 are not getting pregnant. But now we're getting to the point now where many of our patients who are pregnant patients have been offered the vaccine. And I have told them categorically that they should get the vaccine because they could still contract COVID, and they could still get very sick from COVID. And some of the worst things that happen for patients who have COVID and are pregnant is they could still end up very sick in the hospital, in the ICU, on a ventilator. And these things still have a lot of ramifications. One way that we know we can protect and prevent patients from getting COVID sickness to the worst degree is actually the vaccine. So they are usually concerned about how safe is it for my baby, or how safe it is for me. And one thing I tell them is that it's probably been, very well studied in many patient groups, but we didn't study in any pregnant patients. Neither would we study any vaccines in any pregnant patients. But we have a lot of evidence from previous vaccines that show us that this is very safe. And they are always happy with that. One thing that I've always said to them too is that the one thing that they ask is, does it change the DNA? Does it change the DNA of my cells to make it difficult for me to get pregnant in the future? And I've also said to them that categorically, no, there is no alteration in your DNA. Nothing changes regarding this. And, one of the things that I take them back to is when there was a vaccine in the past, which was the HPV vaccine. That was the biggest question we had to answer at that point in time, was with the Gardasil, which is one of the vaccines that we used to give for HPV. The biggest concern was that, would it change my DNA so that my children, or would it change my daughter's DNA so that they can't get pregnant? The answer to that was also no. So this vaccine is very safe, and I have reassured all my patients that they should get the vaccine as soon as they have the opportunity for it, because they want to be safe. And one of the best ways in which they can protect their babies or protect their children when they're born is to be able to develop the antibodies. Hopefully, then they can transfer those antibodies to the baby. Majority of the immunity that babies have in between when they're born to when they're 6 months of life come from the mom. And so once the mom has got the vaccine, they develop a lot of antibodies to COVID, which then goes in their blood to the baby. So the baby is protected in the first few months of life. Thank you.
The next question is for Dr. Galloway. So this is someone who had COVID in October 2020, and I've been hearing that the side effects of the vaccine are worse when you had it before. Is this something I should be concerned about? And the second part to that question is I'm not concerned about the short-term effects of the vaccine, but the long-term effects and potential autoimmune issues down the road. Is this a valid concern? So those are two-part questions, two different questions.
Well, I'll try to answer that question. I'm glad I have Dr. Thompson behind me to help me if I get in trouble. But yes, she had, or the person that's asking the question had in October, had the COVID-19 infection. So she has a natural infection. So she has developed natural immunity to the virus. That means her antibodies will react anytime that they are exposed again to or the vaccine or to mostly in this case a vaccine. So the answer to this question depends on many things, on her age and other comorbidities, if she has any other things going on, diabetes, heart disease or lung disease or any other diseases. That'll depend on the response. If she has a very strong immune system, she will have a stronger response. And that's actually not a bad thing. You get a good response, that means your immune system is very good. So there is a possibility that after the first infection or after a natural infection to the COVID, when you get the vaccine, you may have a reaction a little more stronger. So you could have the chills, the fever, the sore arm, the swelling in the arm, all the reactions that we can have to the vaccine. But none of them will be life-threatening or dangerous. And we are actually wanting people to get the vaccine because that natural immunity that we got from the disease, we don't know how long it's going to be with us. The studies are variable. Some say 6 months, 8 months. Some say more months than that, but we're not sure. We think this is, medicine is constantly changing. What I can say today as an absolute truth might change tomorrow. So, but what we think of today, that those people who've had the disease should get the vaccine. They will have a stronger response, possibly. It depends on how much, like I said, underlying conditions and how strong was the first response. And sometimes the first response also depends on how much virus that person was exposed to. If there's a smaller amount of virus in that first infection, it might have a smaller immune response. So hopefully all the people who've had the illness and the disease will go ahead and get the vaccine. That's what the current recommendations. Now, CDC isn't very strong on this point, but they're saying around 90 days after the infection, you should get the vaccine. One of the reasons they're doing that 90 days, I think, is to give other people opportunity to get the vaccine, since we're trying to get as many people vaccinated at this moment. And of course, the persons who've never had the like Dr. Thompson explained, if they have never had the disease, they are at higher risk, of course, of dying and having all the complications. And so if you've already had the disease, of course, you have some natural immunity that protects you. But the second question, could you repeat it?
Okay, sorry, I apologize. It was two questions. So the first one was they had COVID and they had heard about the side effects of the vaccine are worse than when you've had it before, and they were concerned about that. The second question is, I'm not concerned about, and this is a different person, I'm not concerned about the short-term effects of the vaccine, but the long-term effects and potential autoimmune issues down the road. Is this a valid concern?
The honest answer, we don't know yet what could be, but there are ongoing research up to now. All the information we have up to now says there's no long-term damage to any immune system. actually we're having a good response to the virus, and that's protecting us in the future. And like we all know, it will not change my DNA. It will not change the capacity of my body to respond in the future to any other infection. There's an ongoing on all the patients, all the persons who participated in the COVID research, the first in the stage 3 research studies. They're still ongoing. It's going to go for 2 years. I would not be able to tell you exactly how much time they already have. It's probably quite a few months since the first group. I think it was July, August. So we're probably around month eight after that first group was studied on the stage 3 of the research study. So we're looking at it. However, it is not a big concern for most of the researchers. They say we're looking at it. We don't, all vaccines, any vaccine, any medicine can have long-term effects we don't know about. And until we study them, we're not sure. And I think most experts will say that, but we should not be afraid to get the vaccine because of that. The vaccine is effective and it protects us against the infection. And actually, I think we've undersold this vaccine. This vaccine is a breakthrough, a huge breakthrough in medicine. And we will be using this knowledge that we've had these last months for many other diseases in the future. That's what I think is going to happen. It's been a huge breakthrough, and actually, we as physicians and healthcare, we should be very enthusiastic about how all this came about. This is almost like getting to the moon. This was something really positive in the field of medicine, and like we've seen. All races, all groups were involved. So there's no concerns that it's going to be just for certain group of people. It's going to be effective for everyone. And that's a message I would like to transmit.
Thank you, Dr. Galloway. I think, I'm not sure if Dr. Thompson would like to add anything to that.
Sure, I would just say that Dr. Galloway did a very good job. He hit all the bases. There's really no evidence of concern at this point. Now going back several months, if you go back to phase 1 studies that were taking place just in the summer of last year, those people are still part of the study and they're being followed and giving blood to see what's going on. And there's no evidence of autoimmunity of cells reacting against themselves. So we're happy to see that that's the case, but time will tell. But the outlook is good because already upwards of 40 million people have been vaccinated in this country without that surfacing, as well as 100 million if you include globally. And this has been a global monitoring situation. So far, so good.
Thank you, Dr. Galloway and Dr. Thompson. This question actually popped up during your presentation, Dr. Thompson, and it's sort of related to this this type of question, and it goes, can you explain what is meant by long haulers, and are the side effects long?
Okay. Yeah, it's been termed long haul, long haulers. These are symptoms that tend to proceed long after a person's recovered from the acute problem. You may go for weeks feeling, horrible, having fever, either severe where you may have to be hospitalized, but you may survive it, or even mild symptoms. But long after that, after you're no longer having fever, you're able to perhaps return to work or school, some symptoms tend to linger on. They've shown like upwards of 30 to 35% of people may continue to have one or more long haul or long hauler symptoms. These include recurring headaches. It may include brain fog, may be insomnia, depression, aches, joint aches. So for some people, even diabetes. So it covers a large array of symptoms that keep recurring, that don't represent active infection, but the impact of this horrendous inflammatory process that involves certain organs or certain tissues that then tend to leave you with these lingering effects that generally are intermittent, but sometimes can be continuous. And so they've been called long hauler. And that speaks towards the morbidity of this. There's mortality, and it's outrageous that, some 1 to 3% of people may die across the nation. But then you have this roughly a third of people that months later, some people that were sick March, April, May, that are still struggling. I have people sending me disability forms now, and still they want excuses for work or school because they feel like they can't function, or they still have a cough and everybody's looking at them paranoid. So it's a real serious aspect that kind of has gone under the radar. So I'm glad somebody asked that question.
Thank you, Dr. Thompson. This next question is for Dr. Pendleton. I have both Pfizer vaccine shots. Even though I'm protected, could I still be a carrier of COVID-19?
I would say that's probably a good question, but I wouldn't necessarily say someone is a carrier because you had the vaccination, you are actually protected from the virus. You're not considered infectious to keep spreading the virus. I guess when you say carrier, I'm thinking as if you're, more infectious and you can spread the virus and infect others. So I would consider you not to be infectious. And we do have immunologists on the call, so you can help correct me. But once you had the infection initially, when you had your infection and you quarantined how it was recommended, and you're outside the window that's recommended is the 10 days, by the CDC and different things like that. And you, I thought it was 90 days you should wait for the vaccine, but I know it's, that's just a speculation and different things like that. But once you had your vaccination, I do not consider you being a carrier and being infectious, no.
Thank you, Dr. Pendleton. To follow up with that, can I guarantee that I will never get COVID-19?
Unfortunately, nothing is 100%. So just because you get the vaccination, I can't say that you will not get the COVID-19 infection, even though I wish that was the case. I think Pfizer is 95% and Moderna is 94% efficacy, to protect you. So, you still have that, 5 to 6% chance that your vaccine may not have given you immunity. So that is another reason why the CDC and everyone is still recommending that you follow the social distancing guidelines, wearing your face mask and different things in that nature. So no, sorry, I can't ensure that you are 100% protected.
And so what percentage of our population needs to be vaccinated before we can get back to some degree of normalcy? I know, Dr. Thompson, you did mention something about herd immunity in your PowerPoint presentation. I'm not sure if you would like to answer this question.
Sure. Yes, the number you hear mostly is being somewhere north of 70%. When you include the fact that a significant and still growing number of people have had passive immunity, meaning they've had the COVID infection themselves and are likely having some degree of protection from antibodies that they've generated because they simply survived. If you include that with a growing number of people, just south of 2 million a day now, being vaccinated, at some point it is expected that herd immunity should be reached. And once you reach above 70%, you'll likely start seeing that type of protection that you get with herd immunity. If you don't mind, I'd like to backtrack on the last question too about infection. I think it should be made clear that the two studies, the Pfizer, BioNTech and the Moderna study, studied simply the likelihood of becoming symptomatic, having COVID-19 disease. It really didn't study infectivity. So in fact, that's ongoing research to see if one is actually rendered non-infectious by having the vaccine, which is why it's so important to still mask and distance and do all these things, because in fact, you can become a carrier if when you've had the vaccine, because now you won't even know you have been exposed to the virus. You have a 95% chance of not getting sick from it, not having to go to the hospital, likely not dying from it. but not necessarily not being infected. Now, preliminary data for both Moderna and BioNTech do support that a significant number of people are rendered such that they won't communicate, they won't actually get infected, but we're not quite there yet. So you should consider that it's possible for you to get infected and be an asymptomatic carrier. So you want to protect people around you. You're protected symptomatically, but not necessarily from becoming infected or being able to pass it on.
Thank you, Dr. Thompson. The next question I have, and I'm not really sure who to direct it to. If I get the vaccine and go out of the country, then take a COVID-19 test in that country, will I get a positive test if the vaccine puts antibodies in my system? I think it's a very interesting question.
I should probably answer that. It depends on the test. Now, just because you've had the COVID vaccine means you should not have a positive PCR test. That's the test to see if you actually are infected. Now, that doesn't mean you won't, because remember, even though you may have had the vaccine, if you're around somebody that is infected and they cough some aerosols into your nose, remember, you may not have symptoms and you feel normal, but you might still be infected. So that's one scenario where, depending on the test, you may have a positive test despite having had the vaccine. Another scenario is, say you go leave the country, you had the vaccine, and they're checking antibodies. They want to see if you're protected. Well, it depends on the test, but generally you will show that you have antibodies. Now, antibodies do not mean that you have infected. That means you have protection. But when you are vaccinated, there are certain antibodies you make to the spike protein, but there's certain of this are called nucleocapsid antibodies. These are other antibodies to other parts of the virus that you would be negative to. So if you went to another country and they said, well, I want to prove that you're protected, and they looked for just the nucleocapsid antibody, it could be negative even though you're protected because you have the spike protein brought on by the vaccination you had here. So I know I've really made that very complicated, but basically it is a complicated question. But the bottom line is, you could be positive if you travel somewhere else, but if you take that little ticket with you that shows you've had the vaccine, and you've had a vaccine that shows that you're 95%, 94, 95% likely protected from getting sick, that at least is reassuring that you've had something that at least the momentum shows now should protect you and keep you from having the disease that can be passed on.
Thank you, Dr. Thompson, for answering the complicated question. And this would be either for Dr. Galloway or Dr. Pendleton. Can someone take Tylenol or the regular medication the day of their COVID-19 vaccines?
What I had read was that you can take it, but preferably afterwards. They said try not to pre-treat yourself before you get the vaccine. But if you do get symptoms like the body aches, joint aches, headaches, and fever and different things, or then you can take the Tylenol or ibuprofen or NSAIDs. They just want to make sure it's not going to affect your body to mount a response, because as others have said, having a response is a good thing. It's showing your body has noticed these particles in your body and is mounting a response. So having a response, and some people don't like having those side effects, but that actually is a positive, it's a good thing to have a side effect.
Thank you, Dr. Pendleton. The next question is for Dr. Galloway. What if someone has medical issues? Is it safe to take the vaccine, and how will they know what vaccines would affect it? My mom is 77 but has health issues and wants to take it, but I don't know if it's safe.
Thank you for the question. So if she has medical problems, if she gets COVID, she will be at high risk to really get into big problems. So I put it on a balance. Would I prefer the vaccine that has proven to be safe in almost any situation except for anaphylaxis and allergies? But there's actually no contraindication. You can give it to patients who have heart disease, COPD, diabetes uncontrolled, who've had a stroke. I mean, you can give it to any patient who's had any major or any type of medical problem, because precisely those are the ones that if they don't get it and they get the virus, you're going to be, so your mom, if she, God forbid, she gets the virus and she has serious medical problems, she can die. So I would say, let's go for the vaccine. And like we just heard, we're almost at 50 million, and up to our knowledge, there's been hospitalization, but nobody's died from the vaccine. So, and how many people have died from COVID here in this country? We're 500,000 dead. So you put it on a balance. Take the risk of getting a COVID with all the medical problems I have, or go ahead and get the vaccine. So honestly, you have to go for the vaccine.
Thank you, Dr. Galloway. This question is a little more specific. If you are on blood thinners, should you take the vaccine? Dr. Galloway or Dr. Pendleton, whoever.
Since I'm unmuted, I can answer. Yes, you can. Actually, almost any medication. The only, there's been patients who are on immune suppressors, and you say, yes, get them. Your immune response might be less robust as somebody with no immune disorders, but definitely, if you're on the blood thinner, you can. If you're on insulin, you can. If they asked me if someone was antibiotics, again, you can. So basically, almost any situation.
Thank you, Dr. Galloway. The next question is for Dr. Ogunle. I know we had asked if it was safe for pregnant women. Should pregnant women get the vaccine?
Sorry, did you say should pregnant women get the vaccine, or were you going to ask something else?
If they should get it. Mm-hmm.
Yes, pregnant women should definitely get the vaccine. I think there are many diseases that we talk about, and unfortunately, pregnant women are not immune to getting COVID-19. A lot of women who have been pregnant so far have ended up on the sharp end of COVID-19, either being on a ventilator or actually being in ICU for multiple number of days. And we do know that the effect of COVID-19 on a pregnant woman is definitely going to affect their babies. A lot of women would have respiratory problems, difficulties, tiredness. And even though many women are not in that age group that we talk about being very sick, many women who get COVID still have a long-lasting effect of the infection multiple years down the line. So yes, I do say that they should get the vaccine, and more so their babies that are going to be delivered many times soon, they get their immunity only from the mom. So for the first 6 months of life, many babies don't actually start making their own antibodies or their own immunity. So they rely on what they get from mom. So usually if they get a COVID vaccine, the pregnant patients have another opportunity to even protect their babies in addition to protecting themselves. So it's very important that they do.
Thank you, Dr. Ogunle. And this one, I think it's not sure who to direct it to, but whoever has the answer can definitely jump in. Can you get the shingle shots and the COVID shot at the same time?
I'm sorry.
No, you can go ahead.
Okay. This is one of the shots. In pediatrics, we're used to giving multiple shots at a time, but this is one of the shots that you cannot do that. As a matter of fact, it's recommended that you do not have a vaccine 14 days prior to this shot or 14 days after this shot. So you cannot get this shot along with any other vaccine.
Thank you, Dr. Tillman.
May I add something to that? Yeah, it's recommended that there be 2 weeks between vaccines, really any vaccine. So either 2 weeks, before the COVID or 2 weeks before the other vaccine. So it is recommended that there just be enough time, space, and not getting, as mentioned by Dr. Tillman, they shouldn't be given at the same time, but they can be given if it's been 2 or more weeks.
And Dr. Tillman, when will kids get the vaccine, and will the vaccine be required for school admission?
Right now, the Pfizer vaccine is actually approved down to the age of 16, while the Moderna one is only approved down to 18. They're not at the phase yet where they would be the ones to get the vaccine. And as a matter of fact, I asked about 3 of my teenage kids today if they would get the vaccine, and they had to think about it. But I figured I would just put that little nugget in their brains and their mom's brains to let them think about it and give it some thought. I do know that Pfizer is starting some studies for kids 12 to 16, and Moderna is also doing studies from 12 to 17 that they have just started, and I haven't heard anything. I have heard on the news of them saying that they think that kids will start getting it by August, but from what I'm seeing, that seems a little premature to me. But like I said, the 16-year-olds for the Pfizer vaccine, could possibly get it. They just need to consider if they feel comfortable doing it. I feel like it would be safe. I feel like, a lot of times we're given vaccines and the kids don't even know what the condition is. Everyone knows what COVID is, and they know what we're trying to prevent by giving this vaccine. So I'm hoping that will make it a little easier to get them to consider getting the vaccine. But so far, we haven't had I didn't have any luck offering it today. If they had the opportunity, they're still not sure. But I think it's safe, and I think our kids are used to getting vaccines, and I think they're anxious to getting back to school. As pediatricians, again, we look forward to having the opportunity to give the vaccine. So.
Thank you, Dr. Tillman. And this would be for Dr. Galloway. If you already had COVID, would it be safe to get the vaccine? If so, how long should you wait to get the vaccine?
Yes, like we said previously, it is safe to get the vaccine. There's not a set date, but most experts are saying it's 90 days after having the illness. And again, be aware that you may have a very robust response. That means you might have some chills and fever and feeling achy. There has been some talk. This is not proven, so like I said, medicine changes, that someone who's had the vaccine who's had the disease would only need one shot because their immune system would be acting, and would be able to control the illness. But this again is some experts are talking about that possibility. For now, we stay with the 2 doses, if it's Moderna or Pfizer. But that would be, I would say 90 days would be a good time to get the vaccine.
Thank you, Dr. Galloway. The next question is, after a good percentage of people are vaccinated, is it important to continue testing so we know the status of the COVID spread? And this could be for anyone, really, any doctor that would like to answer this question. I'm not sure if Dr. Thompson would want to take this question.
Sure. I think most doctors that are involved with the COVID vaccine and COVID-19 studies and research would answer that right away, saying yes, there should be continued testing. There probably hasn't been enough testing. And the reason why is because what we haven't spoken of much is the variants. And there are variants around this country. There's the original SARS-CoV-2, and then there are variants like from the UK. They have numbers they prefer to use now, B117, and there's one from South Africa also has a different set of numbers, and a Brazilian one. So there are some variants out there that hopefully won't become too instated, although the UK one is likely going to take over in the next month or so. And so that's why it's kind of a race to really get as many people protected as possible before there's enough replication of this virus that it mutates even further away from the protection of these vaccines. The good news is it looks like even this UK, which is somewhere between 30 and 70% more infectious, and some evidence for it being even more lethal, is still susceptible to the two black vaccine platforms. It looks like it still falls under the domain of these vaccines. You can be protected, but they're not sure about some of these other ones, like particularly the one that's from South Africa that is in more than 5 states now, and that but doesn't appear to be ramping up like the UK. So the answer is yes, testing should still be going on, testing and genetic mapping until this thing is really under control.
Thank you, Dr. Thompson. And you're right about the yes part. I did see many doctors nodding their head, and I was like, I don't know who to direct it to, but I see the yes. The next question I have, and this might be for Dr. Pendleton, because I know you had sort of answered this question previously. I take 4 to 6 extra strength Tylenol every day and took some while getting my first Moderna shot. I still have flu-type symptoms. I get my second shot on Thursday. Should I stop taking it before?
Wait, I'm sorry. You said that they still have symptoms from their first shot?
I think I still have flu-like symptoms. I think they took Tylenol, then they took the shot, and then they still have flu-like symptoms. They're getting the second shot on Thursday, and they're asking maybe if they should stop taking the Tylenol before the shot. That's my understanding from the question. I'll read it again. I take 4 to 6 extra strength Tylenols every day and took some while getting my first Moderna shot. I still had flu-type symptoms. I get my second shot on Thursday. Should I stop taking it before?
Well, I think from what my understanding from what I read, and you have Dr. Thompson on the call as well, it's not going to stop the person it's not going to stop you from getting an immune response from getting the vaccination. If it's possible to stop it, I would say stop it. I guess my more concern was if she was, having flu-like symptoms, make sure she doesn't already have a fever or something else, prior to getting the vaccination. I know that most of the studies did say to try to take your vaccination during your scheduled time. So if it was the Pfizer, get it at the 21 days, or if it was the Moderna, get it at the 28 days. But they did also update because, with the vaccine shortages, that they did say if we had to push it out, I think the max was 42 days, which was 6 weeks. But, ideally get it as close to the 3 weeks for the Pfizer or the 4 weeks for the Moderna. So I guess first I want to make sure the person's not, you're not having any fevers or, some other type of infection going on at that exact time. But if you're, routinely taking it, I'm not going to say it's the ultimate contraindication that you cannot take it. They just recommend it if you don't try to pre-treat yourself, to say, I don't want to have fevers or body aches from taking it. So, but my understanding is that it's not going to stop you from mounting an immune response.
Thank you, Dr. Pendleton. The next question is, if I received the vaccine and did not have any symptoms, does that mean that I have a weak immune system? I have heard that having symptoms shows that you have a strong immune system. Dr. Thompson, would you like to answer this question?
Sure. I would generally just reassure that person that not everyone necessarily will have those reactogenic symptoms, a high degree of local soreness or have the fatigue and body aches. Actually, if you look at the 2 studies, the Pfizer-BioNTech, it was just about 5% of people had fatigue and headache, and Moderna was like 8 to 9% had fatigue, headache, body aches. So that means a large percentage of people didn't have those symptoms. And it's hard to find someone that doesn't have a little soreness from the injection site, but you never know. But I would not look at that as an indication of it not working. I would reassure that person if they got their 2 shots, they are likely protected, at least at 95 or 94%.
Thank you, Dr. Thompson. The other questions for Dr. Ogun Lee. Why do I still need to wear a mask and follow social distance rules after I'm completely vaccinated?
Well, that's a good question. And I do think that you possibly can still spread the virus. Now, the vaccine, as much as we know, and like Dr. Thompson said earlier, the vaccine prevents the individual who received the vaccines from being very sick. But don't forget that there's still a lot that we don't know. And there's still a subset of people that are still going to get sick. Even it's not 100%, nothing is 100%. So you want to make sure that the best means of protecting ourselves right now is still a face mask. It's still actually washing your hands. It's still social distancing. Now, we now have on top of that another layer of making sure we don't get sick, which is the vaccine. So just because we have the vaccine that is going to make us not get sick does not mean that you cannot transfer the virus from one person to the other. And one of the things I actually told my patient in the past was, it takes a level of viral replication in one person to be able to pass the virus to so many people. But the vaccine prevents that level of viral replication, but it doesn't still mean that if you don't wash your hands, you can't touch a surface that then moves the virus to someone else. So in some ways, we're trying to kind of cover both sides. Like the vaccine would stop that amount of viral replication that you can pass it to 100 people. But in addition to that, you want to make sure that you can't even pass it to one person or 2 people. And that's what the mask and washing your hands and social distancing will do. So by covering things on both sides, hopefully we can stop this really awful virus.
Thank you, Dr. Ogunli. The next question is, I'm not sure if maybe everybody would like to add a little bit of what they think, but just let me know. In talking about Blacks not taking the COVID-19 vaccine, is this anecdotal or factual information? Or is the lack of people in Black communities not receiving the vaccine due to availability of the vaccine in their communities? If you need me to repeat the question, just please let me know.
I think we're all calculating here.
Can you repeat the first part?
Of course. In talking about Blacks not taking the COVID-19 vaccine, is this anecdotal or factual information? Or is the lack of people in Black communities not receiving the vaccine due to availability of the vaccine in their communities?
I mean, personally, I think it's a combination of both. I think initially, my example is like my family, everyone was on board of not taking the vaccine. And then, me putting my hand up first and being one of the first ones to get the vaccination, and then, realizing that it is safe and different things. I think that brought others to be on board as well. I think it's just education, fear. The Blacks in that community, we had the Tuskegee, thing, and you hear people make reference, I'm not a guinea pig. How did they make the vaccine so fast? So I think it's that fear will make the vaccine so fast. And I try to tell others that when you had a pandemic that was taking so many lives and affected so many people, and when you put all your resources and energy to make this vaccine because it's life or death, yes, we got the vaccine faster than, we thought it had to take years to make or this length of time. So I think it's just initially some of those things was the fear, wanting the vaccine is safe, the reason for the town hall. So I do appreciate the ones who put this together and invited me to be on here. So it's the fear of making sure it's safe. And then the other thing is the availability. The availability is scarce in general, the amount of vaccines that is available, and then the way the vaccines has been rolled out. Some minority communities don't have the facilities in place. I know that, how they said the new president now, maybe was trying to, do at some, even Walgreens or CVS, and then some inner cities may not have these locations to even roll it out to, that we need to go to churches and other places that they feel comfortable getting the vaccine. So I think it's a little bit of a combination of both. And the same.
I have to concur with Dr. Pendleton. I have a little different angle because I'm an optometrist. And one of the things I'm pushing for in this state is for people to go to their optometric office and be able to get the vaccine. Why? Because a lot of times I see people more often than they see their primary care physician. So access to care or access to primary care, a lot of times, it's not even access. It's basically sometimes we wait till the wheel falls off the wagon, and it's so much information, misinformation, as Dr. Pendleton has said, from Tuskegee, and so that's one of the things we founded this foundation to help, and we're so happy to participate, to help be a part of answering people's questions, and they're able to ask questions of doctors that look like them. Not someone on TV that says you need to get this vaccine, you just need to do it. So the trust is an issue, and we all are kind of coming together to do this one person at a time. And then we're going to have some other initiatives on the front line to really help just put the information in people's minds. Our philosophy is we don't tell you yes or no to take the virus, but we're going to give you all the information you need. And if you don't take it and you have all the information, that's on you. And then, just make the best decision you can with the information you have. So that's my kind of viewpoint, meeting people where they are on the front lines. Yes, churches. We saw the power of the Divine Nine with the last presidential election. So getting everybody on board, the NAACP. We have so many multiple organizations that we really need to come together to get this message across.
If I could add to that too, you're right, Dr. Pendleton and Dr. Johnson. I think it's different layers. And so the African-American community, I think, probably bombarded with the amount of social media misinformation that everyone has. So when you have that kind of bombardment of social, of misinformation, then you add on to that the skepticism that many African-Americans probably have had over time from some experiments that have been done, that adds to another level of burden. And so I think that aside, access to the vaccine also makes there be a little bit of either skepticism to say, well, I don't think I'm going to be able to get a vaccine because it's very hard to get a vaccine. So I think those different things, hopefully as time goes on, we can counter those. I was speaking to one of my very good family friends who he is 76. He has renal disease and high blood pressure, and he has heart disease. And when I told him that I'm going to get the vaccine, he said, why are you going to get the vaccine? He said, I'm not getting the vaccine. I said, no, you're getting the vaccine. If I have to drag you over there, I will drag you over there. He said, well, I want everyone else to get the vaccine first. I said, you don't have that luxury of time, that this is very safe. So he said, well, why don't you get the vaccine and tell me how you feel? I said, I am going to be fine. It's you I'm worried about. So I think overall, there is a lot of concern and a lot of misinformation that is out there. And so I keep telling everyone that this is probably one of the best ways that we can stay alive with COVID. And, I think it's important for us to keep spreading the same information. And on another note, I think as we get more opportunity for people to get the vaccine, it's going to demystify getting the vaccine. So I think if only a set of people who, maybe only 10% of people who want the vaccine can get it, then more people would feel like maybe I shouldn't get the vaccine. But the more opportunities there are for people to get the vaccine, and I hope that there will be round-the-clock vaccine clinics that people can just go get the vaccine, be it 11 p.m., be it 1 p.m. I need to kind of say in England, my mom got her vaccine at 11:30, because they opened round-the-clock centers for people to get the vaccine. They made it a point of duty that you can get the vaccine at any time. And people just walk in there, no hindrances, no barriers. They get the vaccine and people can move on. And the quicker we can get this vaccine to many people, the more we can stem the tide of the variants of the COVID virus that is coming out.
Yeah, there's some very, very good answers there. I just like to add that I think if we arm ourselves with tackling the specifics as we come across people and in panels like this, tackle the Tuskegee. Okay, is that your main concern? What's happened since Tuskegee? That was from like 1942 to 1932, I think, 1932 to 1972. Well, what's happened since then? Well, there are review boards now. There are IRBs, internal review boards. There are monitoring agencies. There are more people on both sides of that exam table that are people of color. So I think pointing out some of these things help, as well as addressing, almost line item. Okay, it came too fast. Well, now we're armed with knowing, well, these are the reasons why they were able to go so fast. And, with technology, you look at telephones or computers rather. Remember dial up back in the early 90s? Well, now we have little computers in our hands that we use every day. So that's a leap in technology, which they've been able to accomplish with virology and vaccines. So a lot of times when you explain these things line item, even though it may not change minds at that time, it plants some seeds that, okay, maybe the foundation of my resistance here may not be all that strong. Maybe there's some second thoughts.
As a pediatrician, we give vaccines all the time, and I have my patients I've seen for 15 years, and I'll see that they're not a family that gives the flu shot. I offer it every year anyway. And every once in a while, they'll say, it's been a bad flu season this year, and I'll take it. Or I've had kids whose parents never gave them vaccines, and they're 15 years old, and they come in for their well check, and their mom says, you know what, he decided he wants to start his vaccines. So it's like you just have to keep offering and never give up, and hopefully just keep those lines of communication open, and eventually, they will understand it and decide to get it. It's just like every time when the HPV came out, there's always that initial resistance, and finally, keep offering, give them every opportunity, and finally, you get a yes after 10 years of trying. So you just don't stop.
If I may add something else to this discussion, no one has asked about this question, but the vaccine did not utilize fetal tissue. I think there was a question that one of my patients actually asked me last week, that is this vaccine, did it use fetal tissue? There is this vaccine, at least the ones that we're getting, Moderna and Pfizer, there is no fetal tissue used, neither is the technology for the other vaccines.
And I just want to say one thing. I know Dr. Thompson probably said in his presentation, just want to remind the viewers that the vaccine is inactive. Always, I know initially I had patients or people saying, I don't want to get the vaccine, I'm going to get COVID. I said, no, you want to get the vaccine. So hopefully you don't, get COVID or, get something and get hospitalized or different things like that. So I know that's a big fear that I know a lot of people were saying, I don't want to take the vaccine because I don't want to get COVID. So just want to make sure people are reminded of that. And, myself as a hospitalist, seeing these patients and different things like that. And that was my also, motivation too. I did not want to get COVID. I did not want to, I'm a young person, but I've seen, young patients get really sick and get on ventilators as well. So, obviously most young people chances are better than older, but we had a few, that didn't have the outcome that we would have liked. So once again, I just want to put my push out there for everyone to get the vaccine if you can.
One thing I want to point out too, with the new Johnson & Johnson vaccine that does not require the deep refrigeration, I mean, that's going to really be a game changer in terms of access. So one shot, keep it in a regular refrigerator. So that technology is really gonna help accessibility of the virus a whole lot. So, but in the meantime, don't wait. My advice to people is, if you have the opportunity to take the vaccine, take that opportunity.
Speaking of opportunities, if you don't mind, I see we're getting close to the end of the hour. I'd be remiss if I didn't bring up the point too that we have an opportunity as we talk with patients that to reflect that the comorbidities that are so much spoken about, talked about, diabetes, hypertension, obesity, these are all lifestyle diseases. I mean, this is an opportunity too, ironically, with people sitting shelter in place at home, there's less activity, there's probably eating more fast food, but this is a time to point that out and point out to people that perhaps were involved with going to the gym or something, that you've got to exercise at home. You've got to stay active. You've got to make good food choices, do some cooking, and have some fruits and vegetables and greens, and whole grains. And I think we need to take the opportunity to point to the direction of what makes the high risk group people of color, where there's 2 to 5 times the degree of mortality. So I don't think we should, vaccines and masking and all that is very important, but I think we should also open up that discussion. And that's part of the mission of our foundation, is to address something that's been there for decades, for over 100 years. The fact that we are at higher risk for these diseases that for many years has been killing people of color at a higher rate than others because of lifestyle issues.
Thank you, everyone, for that discussion that sprung from that question. It was a very good discussion. We are getting close to that time. I'm not sure if we have time to answer it. I know there's a few questions that did pop in the chat. And maybe we could answer maybe one last question here. When will the FDA approve rather than grant emergency approval for these vaccines? And I think that would be the last question we'll be taking. And
sorry, what was the question again?
When will the FDA approve rather than grant emergency approval for these vaccines? Okay.
We really don't know. The early use authorization, people should know, was not a new device either. That's a means of getting something that has at least preliminary data that shows safety and effectiveness out there before millions of people die trying to study it. The FDA usually uses a couple of years of safety data before they approve of a vaccine or drug. But the information, the data from these 2 studies was overwhelming, and appropriately they used the not early, but the emergency use authorization. And so that's good. So we don't know when or if it will be FDA approved. It may be a moot point with all these vaccines being given and without seeing any major problems surfacing. There has been a precedence where I think it was the Ebola vaccine, where it started out with emergency use and then it subsequently got approved by the FDA. But it could go either way.
Thank you so much, Dr. Thompson. Next, we will hear from Ms. Linda Foster, President of the Bloomington-Normal branch of the NAACP.
Thank you so much. What I heard was, let's get protected. I plan on taking the vaccination when I can. Thank you all for the powerful information and statements today. On behalf of the NAACP, National Association for the Advancement of Colored People, I would like to thank the doctors for participating in this important educational event, our moderator, the planners, the sponsors, and the attendees. COVID-19 has revealed the health disparities in our communities and throughout the nation. We will be dealing with the issue of COVID for some time, So we must do all that we can by wearing our masks, physical distancing, when necessary, practicing good hand washing, hygiene, and avoiding large gatherings. Tonight, we wanted you to be able to listen and to be able to ask questions. We know that a lot of information has been disseminated and some is unclear or just not factual. So we wanted you to hear the truth from professionals and those that look like you. We know that matters. Your ability to make up your mind is important to us. And those that, and important to us, your understanding what is best for you is paramount, first and foremost. It is with great intentions that the information provided today was helpful, informative, thought-provoking, transformational, eye-opening, as you are able to make your decision, confirm your thoughts and beliefs, and know that every effort has been put into answering your questions and hopefully eliminating doubts, any apprehensions, or unreadiness. We wanted to equip you with the most up-to-date information, address your conflicts, desires, and fears. The NAACP knows that we are facing the largest public health crisis in more than a century. We also know that Black and brown people are faced with a pandemic that affects the vulnerable, disadvantaged, and the voiceless. The NAACP will continue to be steadfast during this critical time of ensuring that our voices are heard and that collaborative efforts of ensuring supply and demands do not miss us, because your life matters. Thank you.
Thank you, Ms. Foster. Thank you to our presenters and our panel of doctors. Remember, we will have a slide at the end with important COVID-19 information where you can get assistance if needed. We will keep that slide up for several minutes so that you have the time to record that information, or you can take a screenshot of the slide. A special thank you to the hosts and partners of this town hall. The hosts for these town halls are Bloomington-Normal branch of the NAACP, Wayman African Methodist Episcopal Church, Western Avenue Community Center, Culture Fest, Inc., Healthy Living with a Vision. Town hall partners are Advanced Women's Healthcare, African American Ministerial Alliance, Bloomington-Normal, Black Nurses Association of Central Illinois, Carle Health, Chestnut Family Health Center, Community Healthcare Clinic, OSF Healthcare, PAP 211, providing access to health.